Okay. A very warm welcome to everybody today for our Maurice Bloch lecture. I'm Ruchika Gachwani, Senior Research Fellow in Clinical Psychology. Lots of friends and familiar faces. Welcome to you all in the room and online. And there'll just be people trickling in. So it's my timing. It's my great pleasure to introduce Professor Joost Hutsebaut, who's kindly here to examine a viva yesterday along with Katie. So we've got double good news. We've got Dr. Kirsty Collins, who has... And so thank you so much for, taking on this opportunity to present to us. I've been a fan, of course, of the work that you'll be doing. As introductions, Professor Hutsebaut is a clinical psychologist, researcher, and professor at Tilburg University, where he holds the chair in prevention and early intervention of personality pathology, and at De Weesprong, one of the leading specialist centers in Netherlands for treatment and study of personality disorders. Over the course of his career, Professor Hutsebaut has become internationally recognized for his work on personality disorders in adolescents and young adults, especially for pioneering approaches to early intervention and mentalization-based treatment. His work has helped shift the field away from seeing personality disorders as fixed or untreatable conditions and towards approaches grounded in development, prevention, and recovery. He has leading contributions to the assessment of personality functioning, including the development of influential diagnostic instruments and treatment frameworks now used internationally. Alongside his academic work, he has remained deeply engaged in clinical practice, combining theoretical insight with decades of therapeutic experience. I first had the privilege of hearing you speak about why we need to simplify our treatments for borderline personality disorder. This was in Sydney a couple of years ago. His paper, Scorn Not Its Simplicity. It sits on my desk, it's printed, particularly stayed with me, for it's a reminder that effective therapy often begins with therapists being genuine, human, and willing to form real connections with their clients. Today's lecture continues very much in the spirit of Maurice Bloch lectures, intellectually stimulating, interdisciplinary, and deeply engaged with the question of what it means to understand human experience. So please join me in welcoming Professor Joost Hutsebaut.
About a kind of introductions, you're wondering whether it's about yourself or somebody else. I recognize some things and need to go out of this slide. Thanks a lot for inviting me for this lecture. I mean, it's always an honor, I think, to be invited to a lecture that it's named after someone, a person. Even if you don't know this person, if you're invited, it's an honor. If the lecture carries the name of a probably well-known person. And there were, of course, a range of topics that I could choose from. So I choose a topic that lies close to my heart. It's about personalizing early intervention for personality disorders. Who needs what and why? And of course, this is a bit of a controversial topic, personality disorders in young persons. So I thought let's start with something that we will probably all agree upon. And I guess whether you're a clinician or you're a researcher or you're a policymaker, I think what we probably all agree upon is that what's our sort of common mission is to provide appropriate treatments for young persons that are at risk for developing unfavorable outcomes, that are at risk for adverse developmental outcomes. And I think we want to identify them early enough and we want to help them early enough in order to prevent unfavorable outcomes. And I think this is something we could probably all agree upon. And let's see if this works here. Yes. And I think this sort of general mission, it includes 3 aims. And the first aim is about early detection. So can we identify who are these kids at risk, the kids at ultra high risk for developing maladaptive outcomes. And the second and the third are about early intervention. What should we do with these kids at risk? And I think the second challenge is probably to provide rapid response, but also proportionate response. I think there is the very difficult balance in early intervention, because on the one hand, you don't want to provide diagnosis and unnecessary treatments to young persons that are still resilient, that may still come out of the woods themselves. You don't want to over stigmatize them by providing unnecessary diagnosis. But on the other hand, you also don't want to normalize problems when there are true problems. You don't want to sort of delay treatments out of a sort of belief that all will come fine after adolescence. No, if problems are severe in adolescence, you also may need to provide treatments. And we might need to identify who needs what kind of treatment, because maybe if you conclude that treatment is necessary, not everyone needs specialist treatments. We only have very limited resources regarding specialist treatments. So who needs specialist treatments, and why do these young persons at risk need specialist treatments? These are a bit the three topics that I will cover today. And I think we would also all agree upon the fact that if our common aim is to intervene early and to prevent maladaptive developmental outcomes, we should focus for mental problems. We should focus on adolescence and young adulthood. And this is a slide, I think everyone uses this slide. Nobody knows where it comes from. I'm also using this slide again and again because it so clearly visualizes the health burden of mental disease. And there are two things you can see in this slide. And the one thing is very obvious, that mental health problems, as opposed to almost all physical diseases, they emerge early in life. They emerge probably between the age of 10, 12, and 23, 25 years of age. And the second thing what this visualizes is that the health burden stretches beyond adolescence. So we usually have this idea that many mental disorders are time limited. They're limited in time. But actually what we see is that in many cases, even depressive disorders, eating disorders, anxiety disorders, they have a sort of life long course. They persist throughout life. And I think what is crucial, and this is also essential for my presentation today, is to make a sort of distinction between two types of mental problems that seem to emerge in adolescence. And on the one hand, we may have mental problems that are intrinsically related to the developmental period of adolescence, that are limited to adolescence. And this distinction has been first made regarding antisocial behavior. So a distinction between adolescence-limited antisocial behavior, which is probably more hormonally driven, more responding to the developmental challenges in adolescence. And what you see is that these adolescents, they grow out of their antisocial behavior and they grow up to be just regular, normal adults. But then there is another group, a subgroup, which is a bit smaller, who continue to persist having antisocial behavior. And I think this kind of distinction between adolescence limited and life course persistent mental problems isn't only relevant for antisocial behavior. I think it's relevant for many mental health problems. And there's also a sort of hypothesis that it might also be true for personality disorders, that you might have a subgroup of young persons who show or display symptoms of borderline personality disorder, but might grow out of it. But there might be another group that sort of continues to get a worse picture and to continue to have worse developmental outcomes. And actually what we indeed see in adolescence is that the typical symptoms of personality disorders like self-harm or emotional instability, they are much more prevalent than the diagnosis itself. So these are almost common problems in adolescence. So how can we make a distinction between the adolescents for whom these are problems that are related to adolescence, to the developmental challenges of adolescence, and who are the kids that are really at risk, for whom these problems just signify the beginning of long-term persisting problems. And I think, of course, many of the risk factors are beyond our control. I mean, there are probably reasons why some continue to develop mental health problems even beyond adolescence that we don't control, that are probably part of the risk factors of this kids, of this family. But there are some risk factors that we do have control over, and because they are part of our response to the problems these young persons present when they seek help. And I identify three sort of risk factors that we can control. And the first is the duration of untreated illness. This is probably the most important, or one of the most important risk factors that we can clearly control. If we identify emergent problems early enough and we start targeting these problems early enough, we might prevent them from becoming chronic. If you start addressing and treating self-harm or eating problems after a couple of weeks or mostly months, it's much easier to change it and to recover from self-harm or eating problems or whatever problem than if these constitute a sort of chronic pattern of years. If they have become a habitual pattern for dealing with negative emotions, it becomes much more difficult to treat them still. So can we take care that youngsters with acute symptoms are receiving help for these symptoms early enough? And the second one might be the most impactful one, because I think if we think about what makes psychopathology chronic, it probably has to do with the fact that the mental problem starts to affect different areas of life, starts to affect your sort of professional life, leads to school dropout, starts to affect your integration in the labor market. If you don't have anything to do in your life, if you don't have a sort of meaningful daily activity, it's quite difficult to recover, I think, from mental illness. So we have to prevent that the mental problems will start to affect, I think, the school attendance or the integration in the labor markets. If you don't have a social network, it's quite difficult to recover from mental illness. So we have to prevent the mental illness in adolescence to affect social life, to affect a network that is supportive. And we have also to intervene to prevent that the mental problem will start to affect physical health. Because what you often see is that many people with severe mental problems also start to develop all kinds of physical problems. And there comes a sort of vicious cycle in which mental problems affect physical problems affect mental problems, making it much more difficult to recover. So one, I think, of the basic challenges that we need to take care of is to prevent that the problems that occur during adolescence will start to affect these three areas of life. And finally, I think we also have to prevent mental health care services from becoming iatrogenic in themselves. We shouldn't underestimate the fact that we're part of the problems. We might do harm to young persons seeking help and not being met in mental health care services with what they need. And it's, of course, I challenged Christine in the Viva yesterday, and I told her I will always now put this picture in my presentations, because to me it so clearly visualizes how much can go wrong in this small period of time during adolescence. That these are usually children that have some kind of problems, and then they enter into adolescence and the problems just go worse and worse, and there comes comorbidity and there come negative life events, and there come ineffective response from mental health care. And in a period of some years, you can see a sort of vicious cycle taking place in which problems just make themselves worse, until I think when they're entering young early adulthood, it becomes much more difficult to treat these problems. So the basic message, I think, there is a critical period in which we need to intervene to prevent these kind of outcomes, and to prevent also that in adulthood we may need much more treatment to still change this vicious cycle of negative interactions taking place. And regarding the ineffectiveness of treatment, this is a recent report in the Netherlands. And this report documents the treatment trajectories of children and young persons within the region where I'm working. It's the region of Breda. And what you can see in these reports are a lot of numbers that are not at all interesting, but what you can see is that there were 50,000 treatment trajectories initiated by the local communities. And about half of them were really light interventions. And these children and young persons just had enough with one intervention. So I'm wondering, did they need the intervention at all? Maybe these were the resilient young persons that have a small problem, and maybe they would get out of the woods anyway. But then interestingly for the story today is that 1 out of 4 of these adolescents or young persons and children received more than 5 interventions. So they had the one ineffective intervention after the other. These were not all psychotherapeutic interventions, but they tried a light intervention, it failed, and they tried another intervention, it failed, and they tried another intervention, it failed, and again, and again, and again. And what you see in the report is that there is a reduction of referrals to specialist services, because what you see in the report is that once these young persons are being referred to specialist service, they stay in the specialist service and the costs exponentially rise. So this is a sort of incentive for the local communities not to refer, because they know once we start referring, costs will rise exponentially. But of course, when they delay referring, when the youngsters arrive in specialist services, they are much worse than they were some years before. So it's a sort of self-fulfilling prophecy. If you delay referral, of course, costs will increase once you are referring. So I think part of the story is our failure. Our failure, I think, as mental health care services to provide appropriate response to the needs of these young persons. And so the first question is, but who are these young persons? Who are the ones that are prone to get involved in this sequence of ineffective treatments, that are at ultra high risk for not benefiting from treatments, but also at ultra high risk for having all kinds of negative outcomes over the long term? And we did a sort of Delphi study some months ago. It was published to open access some months ago. And we brought together experts from different areas, experts from depressive disorders, eating disorders, PTSD, trauma-related disorders, psychotic disorders, personality disorders. And we asked them, so what do you think, based on your experience, your research, your clinical experience, what causes prognosis to be negative, independent of diagnosis? And 4 major areas came out of the Delphi study. There was agreement upon these 4 major areas. Some factors related to the child, like the biological disposition of the child and personality functioning. Some areas or some factors related to the context of the child, like the trauma, child's developmental trauma, but also the vulnerable family environment, problems at school, problems with peer groups, lack of support for parents. Some characteristics of the symptoms, like early onset, rapid worsening of symptoms, but also the type of symptoms, like dysregulating symptoms, self-harm, voices, dissociation, suicidality. And finally, the attitude of the youngster and the family towards help, based often on repeated negative past experiences with help, a sort of helplessness, but also sort of demoralization, a distrust towards professional help. And if you would sort of make a model to explain and predict who would be most vulnerable for developing chronic psychopathology, it could look a bit like this. There are a range of well-known risk factors independent of diagnosis that put a child at risk. And a child is at risk also for meeting failure in treatment, for failing support. And this might be a sort of mediator that causes problems to become more chronic, that sort of leads to social and societal exclusion and to health problems. So I think probably if we can change the support and the treatment, we might sort of break this pattern that wherein children at risk will necessarily become or develop more chronic psychopathology. And this is a transdiagnostic model. But of course, if you would approach it from a sort of diagnostic perspective, of course, I would argue that personality disorders fits this model the most typical, I think, and I do have some evidence to make this case. And first of all, because we know that interpersonal trauma is one of the strongest risk factors for whatever, I think, mental problem, but it is still more intrinsically related, I think, to personality disorders, probably having to do with the interpersonal aspect of the trauma affecting the representation of oneself and the representation the child has of others, which is at the core of personality pathology. So indeed, there are many studies showing that the odds for developing personality disorders are much higher, or often higher than the odds for other disorders. And second, symptoms of borderline personality disorder usually predict future problems much more than symptoms of other internalizing and externalizing disorders. So there is something in symptoms of personality disorder that seem to be stable, that seems to predict future functioning and future impairments. And this is a study of a Danish group, and they have sort of followed up on these young persons 5 years after treatment, and they found that virtually no one had no problems. So almost all of these youngsters being diagnosed with subthreshold BPD continue to have major problems in their life. And yes, most or only half of them continue to have a personality disorders, but they continue to have many other problems. So maybe stability of the diagnosis in itself might not be too high, but the stability in the fact that they will have problems is extremely high. And what we especially see is that BPD affects someone's psychosocial functioning in the long term. And this is one of the most dramatic examples in which it's a sort of broad register study in Denmark. And they identified the young persons who had a diagnosis of BPD as a teenager. And then they followed up at the age of 20, and they found that youngsters with BPD were 22 times more likely to be unemployed, 15 times more likely to be living on welfare, and they had a 1/3 lower income, and they cost society 5 times more. I think this is the true drama, a study by Lena Hastrup. This is the true drama of BPD and untreated BPD, that it will affect someone's chances in life later on, and especially on this transition from late adolescence to early adulthood, where you have to integrate on the labor market, where you have to develop your social network. BPD might affect these kind of developmental milestones quite strongly. And yes, we do have studies showing that BPD is associated with health problems. The life expectancy of adults with BPD is 20 years less than the life expectancy of normal adults. And they often show a whole range of stress-related medical diseases. And we did a quite recent study showing that the lifestyle habits that probably lead to this kind of diseases already can be seen in adolescents in a very early stage of borderline personality disorder. So they eat less healthy, they move less, they sleep less well, etc. So you see a pattern of unhealthy life habits developing already from a very young age, and probably resulting also in the kind of medical problems these persons will have in their future lives. And finally, what you also see is that these are the patients that drop out of treatment quite a lot. These are the adults with borderline personality disorders have the most treatment trajectories of all patients in mental health care. They have the most different treatment trajectory. They drop out of treatment the most. And also in young persons, you can see that the dropout rate of treatment is more than 80% in regular treatment. So there is something in these young persons that interferes with their commitment with treatment and that makes them vulnerable for dropping out of regular treatments. So whether you like the diagnosis or not, or whether you would agree with me to make a diagnosis or not, I think there's little doubt that the diagnosis is revealing. It sort of identifies a group of young people who begins to develop serious problems at a young age, who experiences a high level of distress, exhibits disruptive symptoms that significantly impact those around them, will continue to face many challenges also in their adult life, is at a significantly increased risk of social disabilities, at a significantly increased risk of developing serious physical health problems, and is less responsive to treatment, and as a result seeks frequent long-term and varied forms of help. And still, I think this diagnosis might not be the perfect identifier. And it has to do with what I told in the beginning, that I think many of the symptoms of BPD can also be seen in adolescents who will not continue to develop BPD as a young adult, like self-harm or emotional instability. And we wanted a study showing that indeed adolescents need to have less personality pathology in order to show these kind of symptoms. So what I will be arguing, and if I would have had more time, I would do it a bit more in detail, but what I would be arguing is that if you combine BPD symptoms with the new concept of personality functioning and impairments in personality functioning, we might narrow a bit the scope, and we might specify a bit more clearly who's at real risk. Because if you have a combination on the one hand of severe impairments in personality functioning with, on the other hand, symptoms of BPD, these might be the youngsters at risk for persisting problems. And I'm not sure whether you're familiar with this new model of personality disorders, because we're in a sort of transition in the field of personality disorders. We're coming from a categorical and typological approach to personality disorders, and probably you're familiar with this kind of diagnosis, and we're in a sort of transition to a more dimensional approach. And the approach is dimensional, but it also puts the core of a personality disorder not so much in the manifest symptoms of the person, but rather in some more latent impairments in personality functioning. So criterion A of this new model is the core criterion, and it's sort of tells you that what's the core of a personality disorder lies in a range of capacities that people with personality pathology have not developed well enough. And these capacities are probably well known to many psychologists and probably also psychiatrists. If you would sort of summarize, in your opinion, what makes someone vulnerable, probably you would come up with these kind of capacities. And we'd probably say that if you're not capable of regulating your emotions, you will become more vulnerable. If you can't live your life according to internalized values and norms, you will be more vulnerable. If you can't give meaning to your own behavior, it might make you more vulnerable. If you're not able to read other people's minds and attune to the feelings of other people, it might make you more vulnerable. If you're not really aware of the impact you have on other people, it also might make you more vulnerable. So these are, as you could see, all kinds of capacities. And in the new alternative model, this is a bit what is the core of personality pathology. It's not a symptom on the outside, it's a capacity on the inside. And the interesting thing is, on the one hand, that I think this is a sort of developmentally sensitive concept of personality pathology, because all these capacities, they start to develop from early life on, and they express themselves differently across the lifespan. But we can assess these kind of capacities also in children and in young adolescents. And on the other hand, I also believe that if we are treating those young persons, this is what we are treating. Then we are helping them with regulating their emotions, with tolerating more closeness in intimate relationships, with accepting more different perspectives from others that could be helpful. So it's a language of psychotherapy, I think, that these capacities also express. And
excuse me, where's this graphic from?
This one? This is the alternative model, level of personality functioning scale. It's in DSM-5. Yeah. And we did a study in which we interviewed adolescents and using this new concept of personality functioning. And the results was quite interesting. On the one hand, we found that it's possible to reliably assess personality functioning impairments in adolescence. I think the average age was 14 and a half years of age. And we also found that impairments in personality functioning seem to be already prevalent before the onset of typical BPD symptoms or typical PD symptoms in general, which could mean that if you want to detect the real vulnerable kids early on, this could be the more sensitive way of doing so. You can already capture the really vulnerable kids before they even show symptoms of personality disorders, before they have started self-harming themselves or showing other problems. So, and we're now doing a study where we use the interview also for younger kids between the age of 10 and 12 years. And it seems it's also feasible to assess personality functioning and thereby identify a vulnerable group of kids before the onset of puberty and before the onset of major problems in adolescence. And what is also interesting is, this is another study we did in adults, is that these impairments in personality functioning are by far the best predictors of long-term outcomes. So we compared these impairments in personality functioning with classic PD symptoms. And we approached these patients after 1 year, and we assessed their symptom burden and their psychosocial disabilities. And we found that impairments in personality functioning were much more predictive of future symptom burden and future psychosocial disabilities, which sort of reflects the fact, I think, that these impairments in personality functioning, they capture something of the core of persisting problems, of the core of persisting vulnerability, much more than symptoms of PD according to the categorical model. And so it's my belief, I think, my understanding, and we need more data, that if you combine, on the one hand, impairments in personality functioning as a more latent underlying vulnerability with symptoms of PD or BPD according to the categorical model, that the combination of those two might be the most predictive to identify this group of vulnerable kids. And we also showed in another study we did that, as I said, self-harm is a rather common problem in adolescence. But self-harm in our clinical population in sort of third-line specialist service is a really different symptom. Self-harm is the symptom most predictive of severe impairments in personality functioning. So it might suggest that you have different types of self-harm, that there is the more innocent type of self-harm, which is on the foundation of a more intact personality functioning, and there is the more impulsive, random, severe form of self-harm, which is probably more on the foundation of severe impairments in personality functioning, more often seen in specialist clinical services. So if you want to identify kids at risk, I think this is a bit what we should look for. To what extent is there interpersonal traumas, particularly sexual abuse? How vulnerable is the child? What's the level of personality functioning? How vulnerable is the context? And you can look at the lack of support from parents and peers, and how intense and especially dysregulating are the symptoms, and how quickly are they worsening. And this might be the risk factors that sort of make up a risk profile for identifying children at risk. And then, of course, the next question is what to do then. So how should early intervention look like? What do we need to do, and why do we need to do what we need to do? And these are the two questions that I started from. How can we provide a rapid response, but also proportionate response? And when and why is specific intervention needed to accommodate the clinical needs of young people and their families? And unfortunately, treatment outcome studies so far don't give a nice picture. I mean, I think today there are about 45 to 50 outcome studies. Most of them are uncontrolled. There are about 10 to 12 randomized controlled studies on treatment for youngsters with BPD. And the results are not very promising, to be honest. The treatment for BPD in adolescents is less effective than in adults. More young people drop out of treatments, and there are even fewer indications that specialized treatments have added values. And there might be several reasons, and we might come back to these reasons, but there's one reason that I want to put forward, a sort of argument we made in one of the papers. Because in many of these studies, because it's an early intervention study, what you see in the studies is that youngsters are being recruited even when they don't meet full criteria of BPD. So they're also already recruited in some studies from 2 BPD criteria on, sometimes from 3 BPD criteria. So what you can see in these samples that you will have adolescents with 2 to 3 features of BPD, and you will have adolescents with a full 9 features of BPD. You will have adolescents who are still going to school or still functioning, and you will have adolescents who have comorbidities and don't function anymore. And still within these studies, we treat them with one same package of treatment, with one size fits all. So it doesn't surprise that for some it might be enough, but for many it might either be too much or either be not enough. And this is a sort of argument, I think, to much more personalized treatments. And personalized medicine comes from oncology, And it assumes that we should tailor treatments rather to the individual than just to the disease or the condition. And the question we need to ask ourselves is, what treatment does this person currently in this phase of the disease or disorder needs? And the idea is a bit that in the studies we have so far, there is no personalized medicine. So we have one size fits all treatments for a very heterogeneous group of young persons. And it comes to no surprise that it doesn't work on average, or it barely works on average. So if we would manage to much more tailor treatments to the specific clinical needs of these young persons in different stages and different phases of the disease, the disorder, maybe we could increase the general effectiveness of our treatments. And this is actually not a problem that's unique to BPD or to personality disorders. Of course, this personalized medicine thing comes from oncology, from medicine. And there also you have this problem of, on the one hand, a wide range of stages and a wide range of risk factors. And we need to match these with a wide range of treatments. And in oncology, what is often used as a sort of additional diagnostic strategy is staging. And staging is actually an assessing of the spread of the disease. So you look at the progress of the disease along a sort of continuum of disease progress, and you assess the progress based upon a number of criteria, like the tumor size or the number of affected lymph nodes or the metastasis throughout the body. And as a result of an assessment of these criteria, you can determine the stage of the specific cancer. And besides staging, there's also risk profiling. And risk profiling is an assessment of the aggressiveness of the disease. So a profile of individual risk factors that allows for an assessment of the likelihood of developing or experiencing recurrence of it. You can have an early stage cancer with a high risk profile. And if this is the case, maybe you don't only want to have surgery, but also follow up with additional treatments like chemotherapy, etc., in order to prevent a relapse, because chance of relapse might be higher when the risk profile is more high risk profile. And in our work the last years, we've been trying to use this kind of concepts also for early intervention for personality disorders. We published, I think, last year, a systematic review on pages in the wide psychiatric fields. And we recently submitted a paper that sort of tries to propose a staging model for personality disorder. And I don't want to go into detail on this paper, but I just want to give you a sort of how it could look like clinically. Because these are all, you could say, patients under the umbrella of personality disorders. And some of them might have a low risk in an early stage, like a 15-year-old girl who started self-harming 4 months ago, experiences mood swings and outbursts of anger, but still attends school and has friends, and has a family history of mental health issues, but still has a supportive family. And you might have a high-risk early-stage adolescence. For example, another girl of 15 years old also started self-harming 4 months ago, but her condition is rapidly worsening. Mother has a BPD, father has an addiction, there's severe emotional neglect over many years, bullied during elementary school, and she experiences a high level of distrust towards help. So you could probably sense that these two girls might need different types of treatments, let alone if we look at these cases several years later in a much later stage. So you could feel that if we treat these 4 patients with one package of treatments, we will probably fail. We need to personalize it, and maybe some of them might not even need treatment or not even specialist treatment, and some might need specialist treatment, but not maybe intensive long-term treatment. Some might still need long-term intensive treatment, which is highly specialized. And the question is, can we identify who needs what? This is a study that we published earlier this year, and it's really, I think it's a really fascinating study. What we did was we sort of tracked patients with BPD issues, not all had a full diagnosis, over the past 2 years, for whom we had sufficient data, because we wanted to have baseline data, but we also wanted to have a sort of follow-up routine outcome monitoring data on their treatment outcomes. And we had 126 patients, most of them were women. And the first question we asked, can we assess their stage and risk profile in a reliable way? So we used their assessment files at the start of their treatment. We blinded the raters, and we found that indeed there is a high level of consensus agreement between two blind raters for determining stage and risk profile. And the interesting thing was that, of course, we're a specialist service, but still about 2/3 of the patients were only referred in a quite late stage. So they only come when problems have been there for years, when there have been several relapses, etc. They only come to a specialist service. And the second question we asked ourselves, can we predict the treatment dosage that these patients had received? And we found indeed an effect of stage on the treatment dosage. We didn't find an effect of risk profile, and the main impact was from stage 1 to stage 2. And this is a very conservative calculation because of the way treatment has been recorded in the Netherlands. So if you have an individual session, and our early intervention programs are usually individual, if you have a session of 45 minutes, it will be registered as 45 minutes of treatment. But if you're having a group session, and most of our later more intensive treatment programs are group, if you have a session of 90 minutes with 10 patients, it will only be registered as 9 minutes. So we found an effect, but it was quite surprising, because actually I think the effect is a sort of large underestimation of the real effect. So the earlier you come into treatment, the less treatments you will receive. But of course, the most important thing is, what will the ultimate outcome of treatment be? So this is not how much you have changed, this is how you leave treatments. How well are you doing when you leave treatments? And we found, again, a strong effect of especially stage 1 on the ultimate treatment effects. And if you're treated in a stage 1, in an early stage, you have a 2 to 4 times more likelihoods to make a full recovery on all aspects that we could measure in the early stage. So the message was quite clear, I think, from this study. If we really want to do a good job, we should focus on early intervention. We should reduce the duration of untreated illness. The earlier you get the proper treatments, the less treatment you need to have the better outcomes. This is a clear finding. I think it's a clear message. So this is, I think, what we should do as a field: reduce the duration of untreated illness and refer these patients to the proper care. What happens? Signed out.
I think Audrey will like back in, so I'm not sure what's happened. Unless it's saying, oh, because it's Zoom, it's 40 minutes. And it's
You can maybe just click off the that box there. No,
Yeah,
down.
Stop sharing me.
No, don't stop sharing. Just here, just click off the X there, and then you'll be able to see the slides. Just here,
Helen, I'll let you
just
go.
there. Ding. That's
I don't want to end me.
so. Yeah, just cancel. Oh, you minimize it.
Audrey will
Minimize. Just minimize it.
just minimize.
Yeah. There you go.
Okay.
Okay. But they might not see the slides.
They might
anymore.
not see the slides, but
We're not sure if they're still
Continue.
there.
Yeah.
We'll see. You're sharing the. Oh, you can still see them here. Okay.
still see them.
Yes.
Liana's just, thanks, Liana. Okay, that's great.
And a second conclusion, I think, is that the modalities or complexity of treatment needed and the treatment dose must be tailored to the stage. So the later the stage, the more treatments you probably need to achieve still okay outcomes. And the last conclusion, which is not really a conclusion from the study, but I think we need to think about how can we tailor the goals to the stage. And maybe when you're treating someone in an early stage, goals can be more ambitious. But maybe when you're only treating someone in a later stage, we must lower down the ambition level. And maybe the goals should be rather focused on stabilizing problems and improving quality of life. Okay. And the interesting thing, and this is the last part of my presentation, is that risk profile didn't seem to matter, which was against our expectations. But I think we have to keep in mind that all of these patients were following treatment in a highly specialist MBT treatment program. And when you compare this with regular care, you can see a huge difference. In regular care, young people often drop out of treatment. In a study by O'Dwyer in Headspace in Australia, more than 80% dropped out within the first 10 sessions, most of them after 2 to 3 or 3 to 4 sessions. when they were suffering from borderline personality disorder issues. And we know from studies, from research, that young persons drop out usually when something happens within the therapeutic relationship, when they experience a sort of breakdown in communication, when they experience something is not matching with this therapist, and when these breakdowns are not being discussed and not being resolved. So this, I think, has to do with this failing support. And probably if you sort of put it all a bit together, you could say that what makes a high-risk profile is determined by interpersonal trauma, by the vulnerable context. And this creates a young person with severe impairments in personality functioning, meaning there is a high level of interpersonal sensitivity. And these young persons are in a therapeutic alliance with a therapist who might not always be skills to deal with these therapeutic, with this interpersonal sensitivity, might lead to ruptures in the therapeutic relationship. And I put some concepts, and it doesn't matter if you don't get them, but many of these young persons are often hypermentalized. They're very quickly projecting things about the therapist, like he doesn't care about me or she doesn't believe me. And they have a deep feeling of epistemic mistrust, of a sort of not believing that anybody else can be of help to them, which might lead to ineffective treatment if, as a therapist, you don't have a framework to work with what's happening within the therapeutic relationship. And I think in many regular services, many therapists lack this kind of framework. And I think a PD-oriented treatment offers this kind of framework. So whereas the stage might predict how much treatment is needed and how intensive the treatment should be, probably the risk profile is important predicts how important it is for the treatment to be tailored to the interpersonal sensitivity and how high the risk of treatment resistance or non-response is if it is not. And I think what matters, especially for adolescents, and then I come back to the introduction of Ruchika, is that it matters the authenticity. These are young persons that will feel very quickly that the therapist is not really authentic. And this is crucial. And when we're relying too much upon methods and techniques without this very strong, authentic bonds with the young person, it can lead to unpleasant experiences. So there are some studies, we also did a study showing that often young persons after treatment feel worse and they don't feel supported. They feel probably the therapy did its job. It sort of triggers negative emotions, but the young person doesn't feel supported to carry these negative emotions, leading them to drop out of treatments. So above all, I think practitioners must establish a genuine connection with young people and parents. They need to be trustworthy, transparent, authentic. And treatment should be tailored to the severity of the vulnerability of these young persons. So it should be more specialized when the vulnerability is higher. And it should also be tailored to the stage of the problem. It should be more intensive when the stage is a sort of later stage. Appropriate treatment tailored to the severity should preferably be initiated early. I think this is what we all need to take care of in our field, to initiate early intervention. And treatment must also take into account the social context of the young person. So these are my take-homes. I think we really need to identify vulnerable youth more quickly. This is, I think, at the core of an early intervention paradigm, that we identify who are these young persons that start to display symptoms in adolescence, but they will persist, continue to have symptoms also beyond adolescence. And we need to provide, especially these young people, rapid access to effective interventions that should be tailored to the stage of the personality problems. And regardless of the stage, intervention tailored to PD may be needed for these high-risk children. This is my last slide. Thank you.
Thank you so much. And I'm so sorry about that glitch. That was not, well, happened. So thank you very much. Things happen. Yeah, I'll welcome you all to, questions, reflections. And I think there are people posting online as well. So I'm just going to come here. But yeah, open up to the room.
Curious if we could say a little bit more about the types of treatments that you mentioned, high medicalization or medicalization therapy, but I'm just
the type of treatment we have in our center, yes.
Yeah.
I think we have two types. Well, major types of treatment. One is more specialist, the mentalization-based treatment, comes in two formats. An early intervention format, which is a brief format. It's actually 16 to 20 sessions with one therapist, and the therapist can either meet the young person individually or meet the young person with their parents or with a teacher or with whoever, etc. So this is a time-limited intervention, 3 to 4 months, mainly for young persons who start to get worse. So you want to be there, but they usually still go to school. They usually are still okay at home, so it's manageable, their condition, you could say. And then we have a more intensive MBT program, which is, I think, a year long. It combines individual, group, and family therapy. And this is for youngsters that are, well, in a later stage. So they have usually, I think what to me is very important is, are they still functioning well in their daily life? If so, we can try an early intervention. If not, when they're dropping out of school, when the family can't manage anymore, I think we will probably go to the MBTA program. So this is a specialist intervention, and besides that, we also have a more generalist intervention, which is our KID-PD program. It's more a sort of common factors program. The disadvantage, I think, of the specialist program is that it takes quite a lot of time before therapists are really trained well enough in the method, before they feel comfortable enough with the method. So we needed to have a sort of alternative where therapist practitioners could be much more quickly sort of feeling comfortable, and this is our common factors approach. And usually when I think the risk profile is not extremely high, they would rather go to these generalist treatment programs. So when the risk profile is higher, meaning there's often trauma, there's often severe impairments in personality function, we would refer them to the specialist services, either MBT early in an early stage, MBT for adolescents in a later stage. When they are still in sort of lower risk profile, we would refer them to these generalist treatment programs. This is the way we organized it, and then you have to do it this way. Yeah.
Can I just ask if any non-clinical interventions have any strong evidence? Peer support interventions, other community-based
So if there is any evidence-based or
non-clinical interventions, so peer support interventions, community-based interventions, other
personality disorders in particular, I'm not aware. I mean, surely not. I'm quite confident not for adolescents. There might be some, I think, digital interventions, for example, that have some evidence based in adults, although I think we have to be careful about the evidence base that's really there. But I'm not aware about peer support and whether there's clear evidence. Maybe outside, I think, the field of personality disorders, but within the field of personality disorders, I'm not aware. I don't.
Sorry.
Yes.
We've done just on a pilot study.
Okay.
Peer support for young people in houses. It's not published yet. Oh, yeah. So that's the only one I know of.
Yeah, and it's published already, or
Not yet.
okay, that's why I couldn't be aware.
You don't know what everyone else's work all the time.
Yes. Okay. Really.
So I'm an adult psychiatrist, so I think maybe a little bit controversial, but I'm thinking about iatrogenic harm, and I'm used to Singapore in adulthood. So I sometimes find that people are worried about iatrogenic harm, so that sometimes we can step away. Do you feel like that, and then end up creating inconsistent care that's really, kind of
I really have problems with the Scottish English. I'm sorry. Can you repeat the question?
So it's about iatrogenic harm.
Yes.
Okay? So I see adults with BPD, and sometimes because the concerns about iatrogenic harm, it means services step back,
Okay.
and then the care is very inconsistent, very fragmented.
Probably this is an example of harm. If you step back, probably.
So I was just wondering, what's your view about that? Should we be stepping back, or should we be maintaining consistent, regular care?
I think it's probably difficult to give a general answer, because on the one hand, I think what we should avoid, because this is harmful, is to make people dependent on treatments. And I think this is probably the pitfall that you're probably referring to, that by all the time stepping in every crisis, we sort of probably reinforce. I think what you want to achieve in treatment is probably that people develop a sort of self-confidence they can deal with struggles in life. And when every time we step in, when there's something going on, we're sort of undermining this self-confidence on the one hand. On the other hand, what I could also imagine is that if we let people struggle with things they cannot manage themselves, it's also harmful. So it's always find a sort of balance, like can you support where support is needed, because people have the inability to self-direct themselves in life and to take responsibility for the issues in life. So you need to support them and you need to take over and step in sometimes without, I think, on the other hand, making them over-dependent on treatment and on the treatment system. And I think this is the very delicate balance that we need to sort of manage in treatment of personality disorder. And I think what typically happens in personality disorders is that we're sort of forced in one of the two extremes. Either we take over all the time or we just, it's your responsibility, now you have to find out yourself, and we step back too much. And I think none of these are probably helpful, but it's to find, I think, the proper balance and still all the time collaborate also with the person in need and also explain. I mean, I can sort of, I don't know, help you to a crisis admission now, but I'm not sure whether this is the right thing to do, because then maybe you will learn that you can't deal yourself. And I'm not sure, like, this is a moment where you could learn to deal yourself with issues that are playing now, or is it asked too much from you? Is it over demanding? Because then, of course, I don't want to send you home and let you suicide yourself. It's not my intention. But of course, if I would send you home and you would manage, then you would gain self-confidence that this is something you can manage in your life. And then it would be a pity if I would have sent you to this crisis unit, etc. So what do you think is now something like this? So, but that's, I think, the art of therapy with these people there, because they are always forcing you in extreme positions. Yeah.
There's a question online, then Louise and Paul, and hopefully we've got 5 minutes. So,
okay,
and we've got 2 questions. So, Liana's asked, would you recommend any universalist approaches to benefit the whole youth population?
Ooh, that's a lot. No, but I think it's we were discussing, of course, I think yesterday also, and the thing is that maybe there are some common skills that all professionals working with youth should be able to have, or something. I think it probably has to do with establishing a relationship, with managing what's happening in a relationship. I think this would be a sort of universal skill that I would hope everyone in mental health care would, at least to some degree, possess.
Fab. Question from Rihanna and Paul, and other questions, is
Send
it okay?
me an email.
Yeah, okay. Louise.
Like, as I studied a sample of personality disorders, you see in clinic, and personality disorders that are maybe less help-seeking, with less distress, and also how people with personality disorders feel about DSM-5 and that removal of a diagnosis.
How people themselves, it's maybe a question you should answer. I'm not sure. I think what my experience is that you have very different voices also within the lived experience community. And some voices, I think, argue very much on making a diagnosis as a sort of pathway to treatment, understanding yourself, having access to helpful resources, etc. And others, I think, would argue against it because of its stigmatizing character. What I think, my personal belief, is that it might depend a lot on how you communicate the diagnosis, on how you explain to someone what's going on and to understand. And what I would hope is that the new dimensional language would be a bit less stigmatizing in itself. But what I also fear is that whatever we would call these problems will become to some degree stigmatizing, because what we are referring to is difficult to handle for the person themselves, but also for the environment. And things that are difficult to handle, whatever label you attach to it, might become stigmatizing. I'm afraid.
We've got 1 more minute, so if
really
it's a
quick question.
okay.
It's in relation to that slide, finding of early intervention. I don't know when that came out, but given the fact that today that children are highly influenced with social media, you know, recently in the news we've heard about very young boys raping girls at very young age. I'm just thinking about whether the age is now shifting below that we should be actually looking at children even in primary school and identify where teachers identify these executive functioning skills or children having behavioural problems, that we shouldn't wait and say, well, no, they should wait for another 5 years because that sort of goes against your what we should be doing.
I think you're right. I think this is an old slide, and I think the age is, and I think also epidemiological studies show it. The age of onset is becoming a bit earlier, especially in girls, I think. And then second, my wife is a teacher, and she talks about the pupils in a class, and I have a bit the arrogance that I know who will be in my sessions after some years. So I do think that teachers probably sense quite well who are the dysregulated kids, because these are the kids, they're always emotionally dysregulated, they can't control their behavior, they're also having issues with other kids, etc. So there are, in every class, there are some kids that I think you can predict. And I think it's the kids that have these impairments in personality functioning. That's my idea. So if we can detect them, and I think what puberty does is that it sort of brings a lot of challenges. So if you're already vulnerable and there comes a lot of challenges, then I think the bomb explodes and problems come. Yeah.
2 brilliant questions from Mark Bailey and Enrico. Sorry we won't be able to take, but please do email yours and just, join me in saying a huge thank you. That was great. All online for joining us as well.